Hello, everyone, and welcome to our module on osteoarthritis. The term arthritis refers to joint inflammation, and typical symptoms of arthritis include joint pain, warmth, and stiffness of the joint. And there are many subtypes or causes of arthritis. I've listed a number of them on the slide here. In this video, we're going to focus on osteoarthritis, which is the most common form of arthritis. It's the form you're most likely to see clinically. It happens to many, many elderly patients. Osteoarthritis involves the synovial joints. So synovial joints are found all over our body. They include many joints in the fingers, the hips, the knees, and all synovial joints look like what's on the screen here. So you've got two bones that come together. Each bone is covered by auricular cartilage, and then on the outside there's a membrane called a synovial membrane. And then within the joint space there is synovial fluid. So this is the typical structure of a synovial joint. A couple of high yield things to know about this, especially in terms of step one. The auricular cartilage is made up of type 2 collagen. That's the type of collagen found in cartilage. And the synovium or the synovial membrane secretes synovial fluid that fills the joint space. And a major component of synovial fluid is hyaluronic acid. There are two key elements of the pathophysiology of osteoarthritis that you need to know for step one. The first one is that in this disorder, hyaline cartilage breaks down. So remember, the hyaline cartilage is on the surface of the bone. So when it breaks down, you get bone on bone, and that's what happens in osteoarthritis. Now, most people know this, but what you may not know is that important to this process is abnormal function of chondrocytes. And there's a lot of basic science literature on this, so it's important that you know that the chondrocytes play a key role in the pathophysiology of osteoarthritis. Chondrocytes are the only cell type found in hyaline cartilage, and they are normally quiescent, but they begin to proliferate in osteoarthritis, and they attempt to repair the cartilage, but the repair is inadequate. They secrete enzymes like proteases. They also secrete cytokines, and this all contributes to the inflammation and breakdown in osteoarthritis. And then eventually they die, and this leads to the exposure of bone. So make sure you know that it's the hyaline cartilage and the abnormal chondrocytes that are key to the development of osteoarthritis. Even though there are cytokines and inflammatory cells involved in osteoarthritis, if you sample the synovial fluid, you will find a relatively low white blood cell count. And for this reason, osteoarthritis is referred to as a non-inflammatory arthritis. Now, this term is technically incorrect because there is inflammation going on in osteoarthritis. But what people mean when they call osteoarthritis non-inflammatory is that the white blood cell count is much lower than it is in other forms of arthritis that are considered inflammatory. Let's take a look at the table on the screen here. The normal white blood cell count in synovial fluid is less than 200. In osteoarthritis, it can range from 200 to 2,000, but it's never more than 2,000. In rheumatoid arthritis and gout, for example, the white blood cell count is typically in the tens of thousands. It can range from 2,000 to 50,000 in both RA and gout. And then septic arthritis is famous for having the highest synovial white blood cell counts. In septic arthritis, it can be greater than 50,000 and even up into the hundreds of thousands. If you take an X-ray image of a joint affected by osteoarthritis, there are a couple of classic X-ray findings that you should be aware of for step one. I've listed all of them on the slide here, and we'll go through these in the next few slides. The first one is joint space narrowing. So on the left side of the screen is a normal knee joint. On the right side of the screen is a knee in a patient with osteoarthritis. And it's very easy to see that the space between the two bones is decreased and the bones are closer together. And like I told you before, the hyaline cartilage gets destroyed and you have bone on top of bone. So it's very easy to understand why there would be narrowing of the joint space. Subchondral sclerosis refers to thickening of the subchondral bone, which is the bone that sits just below hyaline cartilage at the edge of the joint space. When the hyaline cartilage breaks down, you have exposed bone, you can have bone rubbing on bone, and this leads to thickening of the subchondral bone. There can be more collagen laid down, the mineralization can become abnormal, and what this means in terms of an X-ray is the bone will become bright white at the edge of the joint space. You can see that here in this picture, there's a black arrow pointing to it. We've got bright white bone right here at the joint space. That's the bone that would normally sit below hyaline cartilage, the subchondral bone, and that's evidence of subchondral sclerosis, a characteristic finding of osteoarthritis. Osteophytes or bone spurs are also seen in osteoarthritis. These happen because of thickening of the subchondral bone at the joint margins. Basically, it's similar to the process that leads to subchondral stenosis, but it occurs at the edges or margins of the joint, often at the insertion points of tendons or ligaments. So if you look on the left side of the screen, there's a bone spur right here. I've zoomed in on it so you can see that there's this bone growth out from the joint, right at subchondral bone. That's evidence of subchondral sclerosis, a characteristic finding of osteoarthritis. Osteophytes or bone spurs are also seen in osteoarthritis. These happen because of thickening of the subchondral bone at the joint margins. Basically, it's similar to the process that leads to subchondral stenosis, but it occurs at the edges or margins of the joint, often at the insertion points of tendons or ligaments. So if you look on the left side of the screen, there's a bone spur right here. I've zoomed in on it so you can see that there's this bone growth out from the joint. That's an osteophyte or bone spur. And lastly, you can see on X-ray subchondral cysts. These are fluid-filled sacs at the edge of the joint. These happen because the bone breaks down and forms cracks, and synovial fluid fills the cracks and accumulates, and this leads to a finding called a subchondral cyst. There's one shown on the screen here. There's a white arrow pointing at a black space in the bone just off the joint space. That's a subchondral cyst that you can see in osteoarthritis. Osteoarthritis commonly involves the knee, and when it does, it often involves both knees. That's because when we stand, we put a lot of weight on our knees. And it turns out that we bear more weight on the medial side of our knee compared to the lateral side. So on imaging, you may see asymmetric narrowing on the medial side. This is an example of that shown on the screen here. You can see that the medial side here is much narrower compared to the lateral side. Osteoarthritis often involves both knees. That's because when we stand, we put a lot of weight on our knees. And it turns out that we bear more weight on the medial side of our knee compared to the lateral side. So on imaging, you may see asymmetric narrowing on the medial side. This is an example of that shown. The screen here, you can see that the medial side here is much narrower compared to the lateral side. Osteoarthritis often involves the hands. It classically involves the joints at the ends of the fingers, so the DIP joints and the PIP joints, but usually not the MCP joints. And this is an important contrast with rheumatoid arthritis, which often involves the MCP joint. So if we look at this drawing on the screen here, the DIP joints are usually involved, the PIP joints are involved, but not the MCP joints right here. And in terms of the thumb, the classic joint to be involved is the first carpometacarpal joint, which is this joint right here at the carpal bones. On this slide, I've shown a drawing of the hand bones next to an X-ray of the hand bones, and I've indicated the joints that are involved. It tends to be the joints at the ends of the fingers. And the way I've always remembered this is that osteoarthritis occurs in elderly patients, so it occurs at the end of our lives, and it occurs at the ends of our fingers. That's always worked for me. And here's one more picture with an actual hand. They like to show you X-rays or pictures of people's hands and ask you which joints are involved. So I've indicated here, again, it's the joints at the ends of the fingers that are typically involved. In some patients with osteoarthritis, they develop swellings in the joints of the fingers. And when this happens, those swellings are called nodes. So this is called nodal osteoarthritis. There are two types of nodes that can be seen in osteoarthritis. Heberden's nodes are the distal nodes, and Bouchard's nodes are the more proximal nodes. I'll show you a picture of this in a minute. These occur in patients who already have osteoarthritis involving the interphalangeal joints of the hands. Over years, the joints become less painful and the inflammatory signs subside, but then these swellings or nodes develop and remain behind. They're common in the index and middle fingers in particular, and these are believed to be caused by osteophytes that are left behind from burned out osteoarthritis. Here's a picture of all of nodes that can be seen in osteoarthritis. Heberden's nodes are the distal nodes, and Bouchard's nodes are the more proximal nodes. I'll show you a picture of this in a minute. These occur in patients who already have osteoarthritis involving the interphalangeal joints of the hands. Over years, the joints become less painful and the inflammatory signs subside, but then these swellings or nodes develop and remain behind. They're common in the index and middle fingers in particular, and these are believed to be caused by osteophytes that are left behind from burned out osteoarthritis. Here's a picture of a patient with nodal osteoarthritis. These more distal nodes are called Heberden's nodes. Nodes at the more proximal joints are called Bouchard's nodes. So we've talked about the knees and the fingers. Now I'll run through some of the other joints where osteoarthritis can develop. You can see osteoarthritis in the spine. The facet joints are synovial joints. The facet joints are the connection between two vertebrae. They're shown in purple. Screen here. You can see osteoarthritis in the spine. The facet joints are synovial joints. The facet joints are the connection between two vertebrae. They're showing in purple in this picture on the screen here. In particular, the facet joints of the cervical spine often lead to neck pain, and the facet joints of the lumbar spine often lead to lower back pain. The hip is another synovial joint often involved in osteoarthritis. This is a drawing of what osteoarthritis looks like. The hyaline cartilage has broken down and there's exposed bone and the joint space is narrowed. And many patients develop hip pain from osteoarthritis. So we've kind of talked about this, but let me go over some details about the symptoms of osteoarthritis. So the hallmark is joint pain, and this is joint pain especially after use of the joint. Osteoarthritis is considered a wear and tear lesion on joints. It often happens in elderly people, which we'll talk about in a minute. So as you use your knee joints or your hips or your fingers through the course of the day, that will lead to pain in those joints, especially at the end of the day for weight-bearing joints like the hips and knees. This is a classic time for those joints to ache in people with osteoarthritis. And overnight, as the patient rests, the symptoms will improve. In addition to joint pain, many people with osteoarthritis complain of stiffness and restricted motion of the joint. The major risk factors for osteoarthritis are shown on this slide. Advanced age is a risk factor. 80% of patients are over 55 years of age. Female gender is also a risk factor, and shown on the screen is a picture of my grandmother to remind you of the typical demographic and elderly female. And remember what I said before, if you remember, osteoarthritis occurs at the end of people's lives. That can remind you that it involves the joints at the ends of the fingers. Obesity is the most important modifiable risk factor for osteoarthritis. You can't do anything about your gender or your age, but you can control your weight. And if you do that, you're less likely to get osteoarthritis. This is especially true at the knee. Many obese patients develop osteoarthritis of the knee because their knees bear more weight compared to an average person. And in addition to the knee, obese people also get more osteoarthritis involving the hands and the hip. And then finally, if you suffered a joint injury to a joint, for example, in the knee or the hip, maybe from a fall or a sports injury as a child or young adult, you are later more likely to develop osteoarthritis in that joint. Treatments for osteoarthritis are listed on this slide. Exercise and weight loss are lifestyle modifications that are very helpful in improving osteoarthritis. It may seem counterintuitive that using the joint with exercise would improve, but patients who are stronger and healthier tend to be able to tolerate the breakdown of the joint better. Pain control is often administered with acetaminophen, which is Tylenol, or nonsteroidal anti-inflammatory drugs, and a very common reason for patients taking chronic NSAIDs is osteoarthritis. Some patients will go to their physician, often an orthopedist, who will administer a glucocorticoid injection into the joint. This is somewhat controversial. It provides short-term pain relief, but it's not been shown to help the joint over long periods of time. However, many patients like these because they provide immediate and short-term pain relief. And then finally, surgery is often indicated for osteoarthritis. If you go into orthopedic surgery, you will spend much of your time operating on knees and performing total knee and hip replacements for patients with osteoarthritis. I'll finish this video by running through a couple of conditions that can sometimes be confused with osteoarthritis. So let's start with rheumatoid arthritis. So in the immunology section, I have an entire video on rheumatoid arthritis. And the reason it's in the immunology section is because rheumatoid arthritis is an autoimmune condition. It's common in women who are aged 40 to 50.
Hello. Hello. Yeah. I'm sorry. Can I can't talk right now. Please, I'm busy. Thank you. Yeah, I've ordered from Zomato. I received the order. Yeah. Okay.
So a much younger demographic compared to osteoarthritis. This is a picture of Lucille Ball, who was an actress, and she's the typical type of person to develop this condition. In contrast to osteoarthritis, if you sample the synovial fluid from a joint in rheumatoid arthritis, you will find a high synovial white blood cell count. I showed you a table earlier showing that the usual white blood cell count is up to 50,000 in patients with rheumatoid arthritis. It's much lower in patients with osteoarthritis. Rheumatoid arthritis classically has morning stiffness and pain that improves with use. These are different from osteoarthritis. In rheumatoid arthritis, as the patient rests at night, inflammatory tissue builds up in the joints, and therefore when the patient wakes up, they are very stiff and painful. As the patient uses the joints, the inflammatory tissue is broken up and it becomes easier to use those joints. This is the opposite of osteoarthritis. And then finally, because rheumatoid arthritis is an autoimmune condition, it has many systemic complications outside of the joints. So patients with RA often have uveitis, serositis, Baker's cysts. And I talk about all of these things in the video in immunology, but you shouldn't see any of this stuff in osteoarthritis, which is a disease process entirely confined to the joint. Septic arthritis is another arthritic condition that can sometimes be confused with osteoarthritis. Septic arthritis has an acute onset, so very different from the slowly progressive onset of osteoarthritis. In addition, osteoarthritis often involves multiple joints, whereas septic arthritis classically involves swelling and pain of a single joint. And you should be aware that if a patient presents with an acute onset monoarthritis, meaning an acute arthritis of a single joint, that's a medical emergency. You need to tap that joint and exclude septic arthritis or gout. Both of these are serious conditions that can progress and destroy the joint. Septic arthritis can even progress to sepsis and death. So you don't want to ever ignore the acute onset of a monoarthritis. In osteoarthritis, patients usually don't have an acute onset. They present with slowly progressive symptoms of multiple joints. In addition to the joint symptoms, patients with septic arthritis often have systemic signs of infection like fevers, chills, and sweats, and you should never see these things in osteoarthritis. And then, as I told you earlier in this video, if you tap the joint of patients with septic arthritis, the synovial fluid will have a very high white count. It's considered purulent and has white blood cell counts ranging up to 150,000, much higher than anything you see in most other forms of arthritis. And then, of course, if you send the synovial fluid for a gram staining culture, it will be positive, indicating the presence of bacteria. Typical bacteria that cause septic arthritis include Staph aureus and Strep pneumoniae. And when these bacteria cause septic arthritis, it's often because they're in the bloodstream. So it's hematogenous spread that seeds the joint. So patients who have a septic joint from one of these bacteria usually also get an evaluation for bacteremia or endocarditis or other signs of blood system infection. And then Neisseria gonorrhea can also cause septic arthritis. As you may know, this is a sexually transmitted infection. So in a board question, this is often going to be a sexually active young person who develops the acute onset of joint swelling. The last disorder I'll mention that can be confused with osteoarthritis is hemochromatosis. I talk about this disorder in a video in the GI section, but by way of review, hemochromatosis is an iron overload disorder. And you should be aware that arthritis is very common in hemochromatosis. If you ever meet anyone with hereditary hemochromatosis, one of their main complaints will be that their joints ache. And in fact, this disorder sometimes presents as arthritis before any of the other features of the disorder develop. Most commonly, it involves the MCP joints. And remember, these are usually not involved in osteoarthritis. It often presents with pain and minimal swelling. And the way to distinguish this, at least in board questions, from osteoarthritis is that it will usually be a younger patient, not an older patient like typically develops OA. And then usually at some point in the question stem, they'll mention that the serum ferritin is elevated. If you see this, you should think that this may be a case of hemochromatosis. It very commonly leads to arthritis and can be confused with osteoarthritis. And that concludes our video on osteoarthritis. Hello, everyone, and welcome to our module on gout. Gout is a disorder in which uric acid deposits in joints. Uric acid will complex with sodium, and when it does so, it's called monosodium uric acid, and this forms crystal structures that deposit in joints. And when they deposit in joints, The crystals are phagocytosed by cells like macrophages and neutrophils. This triggers an inflammatory response, and as a result, patients who have gout have recurrent attacks of acute arthritis when the uric acid crystals deposit. This leads to severe joint pain, redness, swelling, and warmth, all the symptoms of acute arthritis of the joint. One way to think about gout is that in order to get this disorder, you basically need three things. First of all, you need hyperuricemia for some reason, and we'll talk about many causes of hyperuricemia in this video. Secondly, you need cool temperatures. So gout is not going to happen in the middle of the abdomen. It's going to happen in joints that are far away from the body, and therefore they are relatively cooler. And then finally, you need a genetic predisposition. So some people with hyperuricemia do not develop gout, other people do. That's got to do with our genes. The most common location for an attack of gouty arthritis is the base of the great toe. When gout occurs here, it's called podagra. This is a picture of someone with podagra on the screen here. This patient has arthritis of the first metatarsal joint in the foot. That's podagra, a classic location for gout because the temperatures are relatively cool here. Another classic location is in the knee, so an acute attack of arthritis in the knee often represents gout. Patients who have had multiple attacks of gouty arthritis can develop what's known as tophi. Tophi are uric acid collections in the connective tissue, and when patients develop tophi complicating gout, their condition is called chronic tophaceous gout. So places that the tophi often form are the ears, the tendons, the bursa. They're usually not painful or tender, but the patient will notice a little bump, and that is a collection of that can develop what's known as tophi. Tophi are uric acid collections in the connective tissue, and when patients develop tophi complicating gout, their condition is called chronic tophaceous gout. So places that the tophi often form are the ears, the tendons, the bursa. They're usually not painful or tender, but the patient will notice a little bump, and that is a collection of uric acid called a tophi. Usually these bumps form following several attacks of gouty arthritis, and as I said before, they're seen in patients with longstanding hyperuricemia and multiple attacks of gout. Here are some pictures of tophi. This man has one on his ear. This person on the right has one on the knee. And remember, these aren't painful, but they're going to be noticed by the patient. They're going to come to their physician and ask what these represent. Long-standing gout can lead to kidney problems. This is called urate nephropathy or gout nephropathy. And there are many different kidney problems that have been described in patients with gout, but they all relate to the deposition of uric acid crystals in the urine. Two of the complications you should definitely be aware of are that patients with gout can develop uric acid kidney stones. This is a rare type of kidney stone, and I talk about it in detail in the renal section, but just know that patients with gout can develop uric acid kidney stones. And then secondly, patients with long-standing gout often develop chronic renal failure. They often have diabetes and hypertension in addition to gout, but the uric acid crystals in the can develop are that patients with gout can develop uric acid kidney stones. This is a rare type of kidney stone, and I talk about it in detail in the renal section, but just know that patients with gout can develop uric acid kidney stones. And then secondly, patients with long-standing gout often develop chronic renal failure. They often have diabetes and hypertension in addition to gout, but the uric acid crystals in the urine contribute to chronic renal failure. Sometimes these patients with kidney stones. This is a rare type of kidney stone, and I talk about it in detail in the renal section, but just know that patients with gout can develop uric acid kidney stones. And then secondly, patients with long-standing gout often develop chronic renal failure. They often have diabetes and hypertension in addition to gout, but the uric acid crystals in the urine contribute to the chronic renal failures. Sometimes these patients end up on dialysis from end-stage renal disease. In textbooks, you will read about primary versus secondary gout. So let's talk about that now. Most patients with gout have primary gout. In these situations, the gout attack is not due to a disease or a medication. The exact cause is unknown, but it's believed that these patients have some metabolic reason where they overproduce uric acid. So they constantly have mild to moderately high levels of uric acid. And in this setting, a gout attack is easily triggered by certain things you can eat in your diet. We'll talk about that in a minute, or by consumption of alcohol. So these patients are always walking around with a little bit elevated level of uric acid. And then if they eat the wrong thing or drink a bunch of alcohol, they will get a gout attack. Much less common is what's known as secondary gout. This is where patients have a disease or are on a medication that causes them to either overproduce uric acid or under-excrete uric acid. And these cases are called secondary gout. So to understand why diet and alcohol can lead to a gout attack, you need to understand how uric acid is produced. So uric acid is produced from the metabolism of purine nucleotides, and I discussed this in detail in the biochemistry section in the video on purine metabolism. Purine nucleotides have a base with two rings, just like uric acid has two rings. So when the body breaks down adenosine or guanosine, it produces breakdown products with two rings that will ultimately be metabolized into uric acid. The way this happens is the purines like guanosine and adenosine are broken down into a compound called hypoxanthine. This is a breakdown product of the double ring bases found in purines. And then there is an enzyme called xanthine oxidase, which converts hypoxanthine into uric acid. This is how uric acid is produced from purines in our body. So uric acid comes from purines, but where do the purines come from? Well, some purines come from the normal turnover of cells in our body, but some other purine sources are listed on this slide. If you understand these, it's very easy to understand what triggers an attack of gouty arthritis. So red meat contains lots of purines. Red meat is the muscle tissue of animals. It contains their nucleotides and DNA, and when you consume that, you consume purines, which become uric acid. Seafood also contains the meat of fish, and that contains nucleotides, and that leads to a purine load for the body. And then finally, if you have trauma or undergo surgery, there's breakdown of tissue in our body, and this leads to purines in the bloodstream and in tissue beds, and they get broken down into uric acid. And all three of these things are classic causes of a gout attack because they all lead to a purine load in the body, which leads to a uric acid load. Alcohol is another classic trigger for gout, and there are a couple of reasons for this. First of all, metabolism of alcohol consumes ATP, and the A in ATP is for adenosine, which is a purine nucleotide, which is converted into uric acid, and therefore consumption of alcohol can raise the uric acid level by this mechanism. In addition, there is a transporter for uric acid in the kidneys called URAT1, which stands for urate transporter 1. It's a renal uric acid transporter, and it facilitates uric acid excretion in the urine. Basically, it pulls uric acid out of the urine. Well, when alcoholics consume lots of alcohol, they produce lactic acid. And I talk about the reasons why this happens. There is a transporter for uric acid in the kidneys called URAT1, which stands for urate transporter 1. It's a renal uric acid transporter, and it facilitates uric acid excretion in the urine. Basically, it pulls uric acid out of the urine. Well, when alcoholics consume lots of alcohol, they produce lactic acid. And I talk about the reasons why this happens in the biochemistry videos. But when lactic acid is produced, it makes URAT1 more active, and therefore there's increased reabsorption of uric acid. So for both of these reasons, people who consume lots of alcohol can see their uric acid level rise, and that can precipitate a gout attack. Primary gout is also more common among males, and it's also more common among obese patients. So the classic case of an attack of gouty arthritis is an obese male who goes out to a steak or a seafood dinner and consumes lots of alcohol. This patient is setting themselves up for a high uric acid level and an attack of gouty arthritis. Now let's talk about some causes of secondary gout. So uric acid excretion is mostly via the kidneys and urine. And if you understand this, then it's easy to understand a number of the secondary causes of gout. Anything that lowers the glomerular filtration rate will lead to less uric acid excretion, and this can lead to an attack of gouty arthritis. So patients with renal failure commonly develop gout. Patients who are volume depleted have a decreased GFR, and they can develop gout. And then finally, patients on diuretics commonly develop gout. Diuretics do two things. They lower the GFR because they decrease intravascular volume. They also block uric acid secretion in the urine. So for both of these reasons, diuretics can lead to an attack of gouty arthritis. All three of these things shown in this slide are common causes of gout attacks, and it's all because they affect the excretion of uric acid via the kidneys or the urine. Patients with myeloproliferative gout, diuretics do two things. They lower the GFR because they decrease intravascular volume. They also block uric acid secretion in the urine. So for both of these reasons, diuretics can lead to an attack of gouty arthritis. All three of these things shown in this slide are common causes of gout attacks, and it's all because they affect the excretion of uric acid via the kidneys or the urine. Patients with myeloproliferative disorders commonly develop gout. So in the hematology section, I have a video on these disorders where I talk about chronic myeloid leukemia, essential thrombocytosis, and polycythemia vera. All three of these disorders are associated with high levels of cell production and cell turnover. And anytime cells are turning over rapidly, that leads to more metabolism of purine nucleotides, and that leads to hyperuricemia and gout. It's very uncommon for children to develop gout, but one reason they can develop gout is if they have a cytosis. Patients with myeloproliferative disorders commonly develop gout. So in the hematology section, I have a video on these disorders where I talk about chronic myeloid leukemia, essential thrombocytosis, and polycythemia vera. All three of these disorders are associated with high levels of cell production and cell turnover. And anytime cells are turning over rapidly, that leads to more metabolism of purine nucleotides, and that leads to hyperuricemia and gout. It's very uncommon for children to develop gout, but one reason they can develop gout is if they have a rare enzyme deficiency syndrome called the Lesch-Nyhan syndrome. This is caused by an enzyme defect in the purine salvage pathway, and I talk about the purine salvage pathway in detail in the biochemistry video on purine metabolism. This is an X-linked genetic disorder that leads to absence of an enzyme called HGPRT, which stands for hypoxanthine guanine phosphoribosol transferase. If children are born deficient in this enzyme, they have excess uric acid production. I'll show you why in the next slide. This leads to what's known as juvenile gout or gout among children. Now, in addition to the gout, these children typically have severe neurologic impairment. The mechanism of this is unclear. So they classically display hypotonia of their muscle and chorea, which is abnormal movements. They also classically display self-mutilating behavior. So the classic presentation in a board question is a male child with motor symptoms and self-mutilation who also has gout. The purine salvage pathway is a pathway that can recover hypoxanthine and turn it back into purine nucleotides like AMP and GMP. What the enzyme HGRP does is add hypoxanthine to a structure called PRPP and create inosine monophosphate or IMP. This can then be converted into AMP or GMP, which are purine nucleotides. The enzyme xanthine oxidase can break down hypoxanthine, as I told you before, into uric acid. So if children are deficient in HGPRT, they cannot salvage their purines, and therefore, they are all converted into uric acid via xanthine oxidase, and that leads to hyperuricemia and gout. Another rare cause of secondary gout is von Gerk's disease, which is also called glycogen storage disease type 1. And I talk about this disorder in detail in the biochemistry video on glycogen. In von Gerk's disease, children are born with a deficiency of the enzyme glucose 6-phosphatase. This leads to symptoms in infancy. Von Gerk's disease usually presents at about 2 to 6 months of age, and the clinical features are dominated by severe hypoglycemia between meals because of defective glycogen metabolism. These babies will develop seizures, and they can develop a lactic acidosis through the Cori cycle. And as we talked about before, anytime you have an increase in lactate, that can lead to an increase in uric acid. That's because the excretion of lactate and uric acid are linked via the uric acid transporter URAT1. Let's talk about the diagnosis of gout. Which is done via arthrocentesis. This involves inserting a needle into the synovial fluid of a joint and sampling the synovial fluid. In gout, the white blood cell count is elevated, usually 20,000 to 50,000. A normal synovial white count is less than 200, so this is markedly elevated. And then when you examine the synovial fluid under polarized light microscopy, you can visualize the uric acid crystals. Let me briefly explain polarized light microscopy. Normal white light is unpolarized. This means that the light waves vibrate in random directions. But if you use a special tool, you can filter the light and create polarized light where the waves vibrate only in one direction. And then you can bounce the light off an object and see how it is reflected. Objects that are isotropic reflect the light in the same way in all orientations. So, for example, you can imagine an object that's shaped like a ball. No matter how you bounce the polarized light off it, it will reflect in the same way. But objects that are birefringent, like gout crystals, will reflect polarized light in two ways. That's why they're called birefringent. And the reflection is based on the orientation. So when they are parallel to the light rays, they will reflect in one manner. And when they are perpendicular to the light rays, they will reflect in a different manner. Gout crystals are described as negatively birefringent, and they get this name because there are two reflections of polarized light. So if the polarized light hits a gout crystal and the crystal is oriented parallel to the light, that will create one color. If the light hits the crystal when the crystal is perpendicular to the polarized light, that will create a different color. So there are two reflections of polarized light, hence the crystals are birefringent. They are called negatively birefringent because the change in index of refraction going from parallel to perpendicular is negative. You don't need to know the physics behind this, but that's why they're called negatively birefringent. And what this means as a practical matter is that the gout crystals will appear yellow when they are oriented in parallel to the axis of polarization, and they will appear blue when they are oriented perpendicular to the axis of polarization. And the way most medical students have remembered this for years is that the word yellow has two L's and the word parallel has two L's. If you just remember that, you can remember the colors based on orientation of the crystals. So here's a picture of what gout crystals look like under polarized light. First of all, note that they are needle-shaped. That's the classic description of gout crystals, long and needle-shaped. Note that some of them are yellow and some are blue, and the reason they have different colors is because it depends on the orientation of the crystals relative to the polarized light. And that concludes our video on gout. Hello, everyone, and welcome to our module on gout drugs. In this video, I'm going to talk about the treatment of gout. Acute attacks of gouty arthritis are treated with NSAIDs, glucocorticoids, and colchicine. I talk about NSAIDs and glucocorticoids in a video in the immunology section, and I won't review those here, but we will talk about colchicine. And then for patients who have multiple recurrent attacks of gout, they can be placed on preventative therapy to reduce the uric acid level in the body. Drugs that do this are xanthine oxidase inhibitors like allopurinol and febuxostat. There's also a drug called pegloticase, and finally probenecid, and we'll talk about all three of these categories of drugs in this video. Colchicine is a drug that can be used to treat acute gout. Colchicine works by inhibiting microtubules. In the cell biology section in the video on the cytoskeleton, I talk about microtubules in general. They are cytoskeleton elements that are made up of dimers of the protein tubulin. An alpha tubulin molecule and a beta tubulin molecule come together, and then a series of these dimers form microtubules. What colchicine does is bind to tubulin and prevent the polymerization of tubulin into microtubules. When this happens, white blood cells become inhibited. They cannot migrate into the joints, and they cannot phagocytose the uric acid crystals. The main problem with this drug when you use it clinically is the GI side effects. Many patients develop diarrhea, nausea and vomiting, or abdominal pain. And colchicine really is a drug that just has a couple of niche uses, which is high yield for you to remember. So it's used in gout, it's also used in pericarditis, and it's also used in a rare disorder called familial Mediterranean fever. There are two xanthine oxidase inhibitors that can be used for prevention of gout. Those drugs are allopurinol and febuxostat. Both of them inhibit the enzyme xanthine oxidase, which, as I mentioned earlier, converts hypoxanthine into uric acid. So when you inhibit this, you will have less production of uric acid. Allopurinol is a competitive inhibitor. Febuxostat is a non-competitive inhibitor. That's the main difference between the two drugs. Febuxostat is a relatively recent drug on the market. It wasn't available a few years ago. Allopurinol has been around for years. And both of these drugs are given for the prevention of gout attacks. They're also given to prevent tumor lysis syndrome, which we'll talk about in a minute. It's very high yield for you to understand that both of these drugs can abruptly change the serum uric acid level. Now, lowering the level is good, but when you suddenly shift the level from a higher to lower value, that can precipitate gout crystals in the joints and cause a gout attack. So for that reason, anytime you start one of these drugs, you also co-administer NSAIDs or colchicine to prevent patients from developing an acute attack while you're initiating therapy with the xanthine oxidase inhibitor. For many years, allopurinol has been the first-line therapy for patients with recurrent gout attacks. The problem with this drug has always been that a significant percentage of patients cannot tolerate it. The main issue is usually the GI side effects. Many patients develop nausea, vomiting, and diarrhea. In addition, it is metabolized by the liver, so hepatic toxicity can be seen. There's also a hypersensitivity skin rash that occurs in some patients. And then finally, in rare patients, bone marrow suppression occurs. Febuxostat is a newer drug. It's more expensive. It's a second-line agent. It's used for patients who are intolerant of allopurinol. Now, febuxostat still has a significant incidence of these side effects. In particular, many patients still develop GI upset. However, because it has a different chemical structure, it's often tried in patients who are intolerant of allopurinol, and there are many patients who can tolerate febuxostat but not allopurinol. There are two immunosuppressants that interact with the xanthine oxidase inhibitors. Those two immunosuppressants are azathioprine and 6-MP, and I talk about both of these in the video in the immunology section on immunosuppressants. But basically, azathioprine is metabolized into 6-MP, and then they both work the same way to suppress the immune system. But the reason we're talking about them here is because they are both metabolized by xanthine oxidase into an inactive metabolite called thiouric acid. So if you inhibit xanthine oxidase with allopurinol or febuxostat, the level of 6-MP will go up, and that can be a problem. Sometimes this is done on purpose to boost the effects of azathioprine or 6-MP, but it also increases the risk of toxicity. And so for your board exams on step 1, they're going to want you to know that allopurinol and febuxostat will both interact with azathioprine and 6-MP. Next, let's talk about pegloticase. Pegloticase is a drug that has to be administered intravenously. For patients to receive this therapy, they have to go to an infusion center every 2 weeks to get the drug. So for this reason, this is reserved for patients with severe refractory gout. This drug is a recombinant porcine uricase. What this means is that it's a recombinant version of an enzyme called uricase that is found in pigs. And uricase is a uric acid oxidase, and it degrades uric acid. Sometimes this is done on purpose to an infusion center every 2 weeks to get the drug. So for this reason, this is reserved for patients with severe refractory gout. This drug is a recombinant porcine uricase. What this means is that it's a recombinant version of an enzyme called uricase that is found in pigs. And uricase is a uric acid oxidase, and it degrades uric acid. This enzyme is attached to a molecule called polyethylene glycol, or PEG, and by attaching the enzyme to PEG, the half-life is prolonged. That's why you can administer it only every 2 weeks. In addition, by attaching it to PEG, you limit the immune reaction to the drug, and that makes it better tolerated. What pegloticase does is convert uric acid to a substance called allantoin, which is more water soluble and easily excreted by the kidneys. Therefore, when you administer the drug, you get lots of allantoin, it goes into the urine, and the uric acid level will fall. A related drug that is not used for gout is called rasburicase. This is also a recombinant uricase. It also converts uric acid to allantoin, so it will be excreted in the urine. However, rasburicase is not attached to polyethylene glycol. This means it has a rapid on-off action, and it's more immunogenic, and there's more risk of an allergic reaction. This drug is only administered to patients who have the tumor lysis syndrome and need their uric acid level lowered very quickly. So let's talk about the tumor lysis syndrome. This occurs in the treatment of some malignancies. When you administer chemotherapy and there's rapid cell lysis, this can lead to high serum levels of the contents that were inside the cell. So for example, if a patient has leukemia and a white blood cell count of 100,000 and you give them chemotherapy, all those white blood cells start to die and they spill their cell contents. Some of those contents include potassium and phosphate. So the potassium can lead to hyperkalemia and arrhythmias and death. This is a major problem in the tumor lysis syndrome. In addition, the hyperphosphatemia can lead to the binding of calcium and phosphate, and this can lead to hypocalcemia, which is also a major problem in the tumor lysis syndrome. In addition to hyperkalemia and hypocalcemia, however, hyperuricemia is also a major issue in the tumor lysis syndrome. This is from the breakdown of purines found inside those cells. Now, usually this doesn't lead to gout because you need chronic hyperuricemia to get gout. But what this often leads to is uric acid nephropathy and acute renal failure. And for this reason, rasburicase is often administered to help excrete the uric acid. In the setting of tumor lysis syndrome, so patients don't develop acute renal failure. Probenecid is another drug used to prevent gout attacks. It's called a uricosuric drug, and this means that it promotes uric acid excretion in the urine. It does this by blocking the reabsorption of uric acid in the proximal tubule. This is its structure here, and it blocks the reabsorption of uric acid so that more will go out in the urine. A side note here, it also blocks the secretion of penicillin into the urine, and for that reason, it will boost penicillin levels. And in fact, probenecid was originally developed to enhance penicillin effects back when penicillin was the only antibiotic available and some bacteria were resistant. It turned out over time that it also helped in gout. Now it's mostly used for gout. It's a sulfa drug. It has a sulfa moiety in it, so patients who are allergic to sulfa may have an allergic reaction to this drug. And in addition, because it makes more uric acid go into the urine, it can potentially lead to uric acid kidney stones. I'll finish this video by talking about aspirin, which has a peculiar effect on uric acid levels depending on the dose administered. Very high dosages of aspirin, more than 2.6 grams per day, will inhibit uric acid secretion into the urine and reabsorption. And the net effect will be the same as probenecid. The drug will be uricosuric. It will promote uric acid excretion and lower serum uric acid levels. Now, 2.6 grams per day is a huge amount of aspirin. My patients who have coronary disease take only 325 milligrams per day. So it's very unusual that anyone will ever take this much aspirin. At the usual dosages of aspirin, the lower dosages, aspirin inhibits secretion of uric acid only. This means that taking a low dose of aspirin will lead to less uric acid excretion and a higher uric acid level. So for this reason, aspirin is not used for pain control in gout because at the standard low dosages, it will block the secretion of uric acid and raise the uric acid level. And that It's just something you have to know about aspirin. It's got this peculiar so-called bimodal effect that is dose dependent. And that concludes our video on gout drugs. Hello, everyone, and welcome to our module on CPPD. CPPD is calcium pyrophosphate deposition disease, and in this disorder, calcium pyrophosphate deposits in joints and connective tissue. The reasons this happens are not well understood. If you look at the bottom right side of the screen, this is the structure of pyrophosphate. It's two phosphate groups linked by an oxygen atom. And if pyrophosphate binds to calcium, that is calcium pyrophosphate, and that's what deposits in joints and connective tissue in CPPD. And as we'll see, this disorder shares some similarities with gout. In gout, uric acid deposits in joints. In CPPD, it's calcium pyrophosphate. The main difference between gout and CPPD, especially in terms of step one, is that there's a lot of biochemistry around what produces more uric acid and leads to gout. There's not so much biochemistry around CPPD. This is a disorder of older patients. The average age of onset is 72 years old. It occurs in men and women with equal frequency. And there are basically three clinical patterns of CPPD. Many patients are asymptomatic, and the disorder is discovered on routine imaging. There is a variant of CPPD where patients develop an acute arthritis. This is similar to gout. And then finally, many patients with CPPD develop chronic joint disease similar to osteoarthritis. And osteoarthritis and CPPD are both disorders of older patients, and there's a lot of overlap in terms of the symptoms. So let's talk about that first clinical presentation of CPPD, which is asymptomatic disease. So if you study patients and image their joints, you will find lots of joints that have evidence of CPPD but have no symptoms. The only way you can identify the presence of the disease is by seeing the crystal deposits discovered on imaging. So the hallmark of CPPD is something called chondrocalcinosis. This is calcification of the hyaline cartilage from deposition of calcium pyrophosphate. This is an example shown on the screen here. You can see this white stuff here in the joint space. That is chondrocalcinosis. So this is often discovered on imaging when it's done on patients for routine reasons, and it may be discovered in a joint that has no symptoms. That's a very common presentation of CPPD. The second way that CPPD can present is as pseudogout. Pseudogout is an acute attack of arthritis that resembles an attack of gout. That's why it's called pseudogout. And the classic joint to be involved in an attack of pseudogout is the knee. The knee is involved in 50% of cases. Patients present with pain, redness, warmth, and swelling, just as is shown in this picture on the screen here. And gout can also involve the knee, so the only way you can differentiate the two is by aspirating the fluid and sending it for tests, which we'll talk about in a minute. And always keep in mind that if you see a board question describing an acute onset of arthritis of the knee, the three things you should think of are gout, pseudogout, and septic arthritis, and they can all be differentiated by analysis of the synovial fluid. In the video on gout, I talk about a number of classic triggers for an attack of gouty arthritis, and all of those triggers lead to high levels of serum uric acid. There are also some triggers that have been established for pseudogout, although the mechanisms of these triggers are less well understood. So the first thing you should know is that pseudogout often happens to patients who are sick. So if they've had trauma, or they just had surgery, or they have a serious medical illness, these things are all associated with a higher likelihood of developing an attack of pseudogout, and therefore you often see attacks of pseudogout in hospitalized patients. In addition, many flares of pseudogout have been reported after parathyroidectomy for hyperparathyroidism. So when you remove the parathyroid gland, the calcium levels will fluctuate, and so it should be easy to understand that possibly you could see increased calcium pyrophosphate deposition in joints and therefore an attack of pseudogout. The way you differentiate out pseudogout in hospitalized patients. In addition, many flares of pseudogout have been reported after parathyroidectomy for hyperparathyroidism. So when you remove the parathyroid gland, the calcium levels will fluctuate, and so it should be easy to understand that possibly you could see increased calcium pyrophosphate deposition in joints and therefore an attack of pseudogout. The way you differentiate gout from pseudogout is by analyzing the synovial fluid. In pseudogout, you will see crystals in the synovial fluid that are rhomboid in shape. They are positively birefringent, and this is different than gout, where the crystals are negatively birefringent. Gout, you will see crystals in the synovial fluid that are rhomboid in shape. They are positively birefringent, and this is different than gout, where the crystals are negatively birefringent. And in addition, the crystals are blue when they are parallel to the polarized light, in contrast to yellow for gout. And shown on the screen is an example of some of the rhomboid crystals. You can see one right here. So we talked about how CPPD can be asymptomatic and discovered on routine imaging. We also talked about how it can lead to an acute attack of arthritis called pseudogout. The third way that CPPD can present clinically is as chronic joint disease. This is sometimes called pseudo-osteoarthritis because it looks just like osteoarthritis. Patients present with complaints related to progressive joint degeneration. And if you study patients who have asymptomatic CPPD in their joints, about 50% of them will go on to develop chronic joint disease in those joints, similar to osteoarthritis. Basically, what's happening here is the calcium pyrophosphate deposition in the hyaline cartilage leads to progressive cartilage deterioration over time. And that's the same thing that happens in osteoarthritis. The cartilage degenerates and that leads to the condition. So these patients can go on to develop bony enlargement and tenderness, all very similar to osteoarthritis. The treatments for CPPD are shown in this slide. Acute attacks of pseudogout can be treated with joint injections of steroids. This is called intra-articular glucocorticoid injection. Basically, you inject steroids directly into the affected, swollen, and painful joint. You can also treat acute pseudogout attacks with NSAIDs and colchicine. If patients have multiple pseudogout attacks, they can be placed on colchicine chronically as prophylaxis. And then finally, when patients develop chronic joint disease from CPPD, this is basically treated the same way as osteoarthritis. In fact, some people consider the chronic joint disease of CPPD just a variant of osteoarthritis. There are a number of medical conditions that have been shown to increase the likelihood that a patient will develop CPPD. In other words, these conditions are associated with CPPD, and I've written some of them on the screen here. So if you have trauma to a joint, that joint may later in life develop CPPD. Patients with hyperparathyroidism are more likely to develop CPPD, and you know that hyperparathyroidism can raise the serum calcium level, so that makes it easy to remember that it increases the chance of calcium pyrophosphate depositing in joints. And then finally, hemochromatosis is strongly associated with CPPD, and this is a little bit confusing, so let's talk about this now. In the GI section, I have a video on hemochromatosis, and in that video, I talk about how there is a hereditary, show the screen here. So if you have trauma to a joint, that joint may later in life develop CPPD. Patients with hyperparathyroidism are more likely to develop CPPD, and you know that hyperparathyroidism can raise the serum calcium level, so that makes it easy to remember that it increases the chance of calcium pyrophosphate depositing in joints. And then finally, hemochromatosis is strongly associated with CPPD, and this is a little bit confusing, so let's talk about this now. In the GI section, I have a video on hemochromatosis, and in that video, I talk about how there is a hereditary form of this disorder where patients develop iron overload in a number of tissue beds. And in that video, I mentioned that arthritis is common in hemochromatosis, and that's because iron deposits in synovial tissue. If you ever meet a patient with hereditary hemochromatosis, you will find that one of their main complaints is that their joints ache. One of the reasons for this is because of iron deposition in synovial tissue, but another reason is that patients with hemochromatosis very commonly develop calcium pyrophosphate deposition in the hyaline cartilage. 2/3 of patients with hemochromatosis have CPPD. The reason for this association is not understood. This is just something you have to know. But there are two reasons for the joint pain in hemochromatosis. One is iron deposition in the tissues. The other is CPPD, and you just need to be aware of that. And that concludes our video on CPPD. Hello, everyone, and welcome to our module on seronegative spondyloarthritis. The word spondylo means spine, and the word arthritis, as you probably know, means joint inflammation. So in disorders that are called a spondyloarthritis disorder, there is inflammation of the spine. And then the disorders we're going to talk about in this video are called seronegative spondyloarthritis, and they get the name seronegative because in these disorders there is a negative rheumatoid factor test. These conditions were originally thought to resemble rheumatoid arthritis, but they have a negative rheumatoid factor test. Hence, they were called seronegative spondyloarthritis conditions. And these are really a family of conditions, but they all share some common features, which we'll talk about in this video. And the conditions that are considered seronegative spondyloarthritis disorders are ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, and reactive arthritis. And we'll talk about all of these in the next few slides of this video. All of the seronegative spondyloarthritis disorders are autoimmune conditions. They are all mediated by T cells, like this lymphocyte shown on the screen here, and they have an unknown trigger and unknown cause. Before we talk about the symptoms of these disorders, let me review some terminology. So when we say a patient has a monoarthritis, we mean they have arthritis involving one joint. An oligoarthritis is an arthritis condition involving 2 to 4 joints, and a polyarthritis is an arthritis condition involving 5 or more joints. Each of the seronegative spondyloarthritis disorders is a little bit different from the others, but there are some common features that are found in many of these disorders. And if you know what they are, it makes it easier to recognize these conditions in a board question. So the first feature that's common to many of the spondyloarthritis conditions we're going to talk about is asymmetric oligoarthritis. Patients with these disorders often have acute attacks of joint pain and swelling that often involve the lower extremities. They are asymmetric, meaning they only occur on one side of the body, and they are an oligoarthritis, meaning they involve 2 to 4 joints. So if you think about it, this is a very unusual presentation to present to the doctor with complaints of multiple joints on only one side of the body, usually in the lower extremities. For example, a patient may complain of pain in the hip, pain in the knee, and pain at the ankle. That's 3 joints. It's an oligoarthritis, and it's asymmetric on one side of the body. That's an unusual presentation, and it's classic for the seronegative spondyloarthritis conditions. And contrast this with rheumatoid arthritis, which is something that's often confused with the disorders we're going to talk about in this video. Rheumatoid arthritis is symmetric, meaning it usually involves both sides of the body. It's usually a polyarthritis, meaning it involves 5 or more joints, and it often involves the small joints of the hands. Other common features of spondyloarthritis conditions are shown in this slide. So in many of these disorders, there is axial spine inflammation. That's why they are called spondyloarthritis conditions. Classically, this involves the sacroiliac joints, which is in the lower spine and presents as lower back pain. Also, many of these conditions involve dactylitis, that's swelling of the fingers, classically described as sausage digits. This occurs because there's swelling of the soft tissue around the joints in the fingers. And then finally, enthesitis is inflammation of ligament and tendon attachments to bones. This often happens where ligaments insert into the heel, and this leads to heel pain, which is a common feature of many of these disorders. HLA-B27 is a human leukocyte antigen. In the immunology section in the video on transplants, I talk about the human leukocyte antigens. These are antigens that make up the MHC class 1 and class 2 molecules found on the surface of our cells. And there are genes found on chromosome 6 that determine each person's HLA type. For example, the MHC class 1 genes are HLA-A, HLA-B, and HLA-C. And each of us is born with a certain type of HLA-A gene, a certain type of HLA-B gene, and a certain type of HLA-C gene. And this determines which human leukocyte antigens will be on the surface of our cells. If you have the gene for HLA-B27, and therefore you have the B27 antigen on the surface of your cells, you are more likely to develop one of the spondyloarthritis disorders. This HLA type is strongly associated with many of the disorders we'll talk about in this video. For example, 90% of patients with ankylosing spondylitis have the HLA-B27 antigen. 50% of patients with psoriatic arthritis have this antigen. Now, there are many more people with this antigen who never develop ankylosing spondylitis or any spondyloarthritis disorder. So most people who are B27 positive will never develop disease. However, if you do develop disease, you are very likely to have the HLA-B27 antigen. So now let's talk about specific disorders, and we'll begin by discussing ankylosing spondylitis. This is the classic form of seronegative spondyloarthritis. It has many of those common features we talked about just a few slides ago. So this disorder is called a spondylitis because there's inflammation in the spine, and it gets the term ankylosing because ankylosis means new bone formation, and this occurs in the spine in this disorder, and that leads to stiffness of the spine, a hallmark of ankylosing spondylitis. This disorder is more common in males. In a board question, it will almost always be a male, and usually they are relatively young, 20 to 30 years of age when they present. The hallmark of ankylosing spondylitis is inflammatory back pain. This is found in 3/4 of patients. So inflammatory back pain is back pain that tends to occur in younger patients, usually under 40 years of age. It has a slow, insidious onset. It improves with exercise and does not improve with rest. And the pain is often present at night and gets better when the patient wakes up and begins to move. And the idea here is that these patients have inflammatory cells and inflammatory tissue present in the joints of their spine. So when they don't move, that tissue settles and stiffens the spine and causes pain. When they move, it breaks up the inflammatory tissue, and therefore the joint moves more easily and the pain symptoms tend to become less. That is inflammatory back pain. Classically, the back pain involves the sacroiliac joint and leads to what's known as sacroiliitis. So the sacroiliac joint is shown on the slide here. It's the joint between the ilium and the sacrum. If this disorder progresses, it can lead to what's known as the bamboo spine. This is where vertebrae in the spine become fused from new bone development in the spine. That's what the term ankylosis means, new bone development in the spine. So to understand this process, let's look at this picture from the web shown on the screen here. So this is a normal spine with a vertebra and disc. When there's inflammation, that inflammation can involve the facet joint shown here. It can also involve the ligaments around the intervertebral discs. And over time, that inflammation can lead to bone protuberances, and that can eventually lead to a fused disc in the spine. And when you have fusion of the discs with bone growing over the discs, that is called a bamboo spine because it looks like bamboo on X-ray. And here's an X-ray of the bamboo spine. You can see that there's a white line here fusing the vertebrae together. So this patient has fused vertebrae. Their back is going to be very stiff and painful and have extremely limited movement. Enthesitis is another feature of ankylosing spondylitis. Enthesitis, as I mentioned earlier, is inflammation of tendon insertions into bones. Classically, this occurs where the Achilles tendon inserts into the calcaneus bone. So this is your calcaneus bone on your foot, and the Achilles tendon inserts into this bone. You can also see enthesitis where the plantar fascia on the bottom of the foot inserts into the calcaneus bone as well. So inflammation in either of these places will lead to heel pain, and that's a common presenting feature in ankylosing spondylitis, and that's because of the phenomena of enthesitis. Dactylitis also occurs in ankylosing spondylitis. This is swelling of the fingers and toes. This occurs when there is tendon and soft tissue inflammation around joints, and the fingers will look like sausage digits as shown in this picture on the screen here. And in addition to the joint and tendon problems, ankylosing spondylitis often has features outside of the musculoskeletal system. For example, many patients develop uveitis, which is inflammation of the uveal layer of the eye, and some patients even develop aortitis, which is inflammation of the aorta, and this often occurs at the root of the aorta, and that will lead to abnormal function of the aortic valve, so patients with ankylosing spondylitis can develop aortic regurgitation. And then finally, you can also see sometimes in cases of ankylosing spondylitis restrictive lung disease. And the idea here is that the patient's chest wall and spine are poorly mobile because of fusion of those vertebrae, like I showed you before, and that can lead to a restrictive pattern of lung disease. This is an inflammatory condition, so on blood testing, you will see elevation of the acute phase reactants. Most patients have an increased ESR and an increased CRP level as well. And so if you put all the things I've just told you together, you get the classic case that I've shown on the slide. In reality, ankylosing spondylitis is very, very rare, but in a board question, it's probably going to look like what I've shown in this slide here. So it'll be a 25-year-old male with inflammatory back pain and heel pain from enthesitis, swollen fingers and toes from dactylitis. The ESR and CRP will be elevated. The patient will be HLA-B27 positive, and the treatment is with anti-inflammatory drugs. Usually NSAIDs are used, and in some cases, anti-tumor necrosis factor antibodies like infliximab can be used as well. Our next seronegative spondyloarthritis condition is psoriatic arthritis, and as the name implies, this condition involves arthritis that is associated with the skin disease psoriasis. This is a psoriatic plaque shown on the screen here. Patients develop many of these plaques on their body when they have psoriasis. And some of them, although it's a minority, less than 1/3 of psoriasis patients go on to develop psoriatic arthritis, which is one form of a seronegative spondyloarthritis. Patients with psoriasis can develop abnormalities of their fingernails and toenails. For example, they can develop pits in their nails, as is shown in this picture here. They can also develop oncholysis. This is when the nail separates from the underlying nail bed. This is a picture of oncholysis here. This white part should be just at the tip, but here you can see it's extending back into the nail bed. That's evidence of separation of the nail bed. You can also see hyperkeratosis, which is a darkening of the fingernail and toenails. Now, patients who have uncomplicated psoriasis, meaning psoriasis without arthritis, 46% of those patients have nail findings. But patients who have psoriatic arthritis, in addition to psoriasis, 90% of those patients have nail findings. So especially for a board question, if a patient with psoriasis is going to have psoriatic arthritis, they are probably going to have nail findings. So what are the clinical features of psoriatic arthritis? Well, it usually presents as an asymmetric polyarthritis. So it will involve 5 or more joints on one side of the body. And it can mimic rheumatoid arthritis because it often involves the hands, and patients often complain of morning stiffness that improves with use. However, rheumatoid arthritis is classically a bilateral arthritis. This is usually an asymmetric arthritis. A classic joint to be involved in psoriatic arthritis is the distal interphalangeal or DIP joint. So shown on the screen here is a person with swelling of their DIP joint. That's a classic joint to be involved in psoriatic arthritis. And then finally, these patients often have many of the other features of seronegative spondyloarthritis conditions. So they can have sacroiliitis and back pain. They classically have dactylitis. This is very common in psoriatic arthritis. Sausage digits occur in half of patients. And you can imagine if the hand is often involved, it's easy to understand why dactylitis is often a feature. And then finally, these patients sometimes have heel pain from enthesitis. There is a classic hand x-ray finding in psoriatic arthritis. It's called the pencil and cup deformity of the DIP joint. So remember, the DIP joint is commonly involved in psoriatic arthritis, and the distal phalange can become narrowed like this one is here. So people think that looks like a cup, and therefore the middle phalange looks like a pencil inserting into a cup. That's called the pencil and cup deformity, a classic finding in psoriatic arthritis. In the GI section, I have a video on inflammatory bowel disease, including Crohn's disease and ulcerative colitis. These are autoimmune conditions that involve the gastrointestinal tract, but you should be aware that both conditions are frequently complicated by arthritis, and in some cases, the arthritis has features of a seronegative spondyloarthritis. There are generally 2 patterns of arthritis that are seen in IBD. The first one is called the type 1 pattern. It involves usually less than 5 joints, and it involves the large joints like the knees, hips, and shoulders. And in this case, the symptoms often get worse when the GI disease flares. The type 2 pattern tends to involve more than 5 joints. It's usually the small joints of the hands, and this form of arthritis that goes with inflammatory bowel disease is often independent of the gastrointestinal disease. Now, in addition to these 2 patterns of arthritis, you can also sometimes see spondylitis and sacroiliitis. Rarely you can see enthesitis and dactylitis, and because of these features, the arthritis that goes with IBD is often considered a variant of a seronegative spondyloarthritis. The last disorder, symptoms often get worse when the GI disease flares. The type 2 pattern tends to involve more than 5 joints. It's usually the small joints of the hands, and this form of arthritis that goes with inflammatory bowel disease is often independent of the gastrointestinal disease. Now, in addition to these 2 patterns of arthritis, you can also sometimes see spondylitis and sacroiliitis. Rarely you can see enthesitis and dactylitis, and because of these features, the arthritis that goes with IBD is often considered a variant of a seronegative. Spondyloarthritis. The last disorder we'll talk about is reactive arthritis, and it's called reactive because it's an arthritic condition that follows an infection, and therefore it is reacting to the infection. It's a form of spondyloarthritis, and that means it's autoimmune. And this is important for your board. So if they describe to you arthritis following an infection, you might be inclined to think that that's spread of the infection to a joint. However, if it is a case of reactive arthritis, it's actually an autoimmune process triggered by the infection. This form of arthritis occurs days to weeks after an infection. There can be one or multiple joints affected, and it sometimes occurs with dactylitis and enthesitis, and that's why it's considered a form of seronegative spondyloarthritis. And usually this is a temporary condition. The symptoms resolve in a few months to a year. The bacteria that are known to cause infections that trigger reactive arthritis are listed on the slide here. These bacteria either cause a GI infection or a urogenital infection. Some of the GI bacteria that have been associated with reactive arthritis are listed on this slide. Most of these bacteria cause diarrhea. So the classic case would be a patient who had diarrhea followed a few weeks later by a reactive arthritis. In the urogenital tract, the classic bug to cause a reactive arthritis is chlamydia. So this will occur in someone who is sexually active. Remember, chlamydia is a sexually transmitted infection. The person may have urethritis and symptoms like dysuria followed by a reactive arthritis. But remember, in many cases, chlamydia infection is asymptomatic. So this could be someone who doesn't recall having an infection but develops a reactive arthritis. And only when you test the patient will you find out that they have been exposed to chlamydia. The musculoskeletal features of reactive arthritis are all the classic features of seronegative spondyloarthritis that I talked about earlier. So these patients develop an asymmetric oligoarthritis. It will occur 1 to 4 weeks after infection, and it commonly affects the lower extremities, especially the knees. These patients can present with heel pain from enthesitis. They can have sausage digits from dactylitis, and they often have inflammatory low back pain. Now, in addition to the joint symptoms and the musculoskeletal symptoms, reactive arthritis often has other features outside of the musculoskeletal symptoms. One of the classic ones is conjunctivitis, so patients may present with a red eye. They can have dysuria from autoimmune inflammation of the urethra. Also, sometimes patients develop oral ulcers. And there's an old term called Reiter syndrome that's fallen out of favor, but this was taught when I was in medical school. And Reiter syndrome referred to arthritis, urethritis, and conjunctivitis following an infection, such as one of the triggering infections we've seen before. Really, Reiter syndrome is just another form of reactive arthritis. It's an autoimmune attack to multiple parts of the body following a triggering infection. And that concludes our video on seronegative spondyloarthritis. Hello,
Ho Chi Minh Chi Wow. Oh, wow. Let's see. So this.
Hello, everyone, and welcome to our module on muscle disorders. Let's start by talking about polymyalgia rheumatica. This is an inflammatory disorder, and this is an important point to remember because, as we'll talk about in a minute, in this disorder, blood levels of CRP and the erythrocyte sedimentation rate are elevated, and that's because inflammation is involved. The cause is unknown. This is a disease of older patients. The typical age is over 50, and many patients I treat who have this disorder are in their 70s or 80s. The main symptoms are muscle pain and stiffness, and we'll talk more about that in a minute. And this is a disorder that is diagnosed clinically. There's no pathognomonic test. There's no biopsy specimen you need to be aware of. Basically, if the patient has the classic symptoms and signs of inflammation, that's how you make the disorder. And a very high yield thing for you to know about polymyalgia rheumatica is that it commonly occurs together with temporal arteritis. In the immunology section, in the video on vasculitis syndromes, I talk about temporal arteritis, which involves inflammation of the temporal artery that can lead to headaches and blindness. So many patients who have temporal arteritis also have polymyalgia rheumatica. The two disorders classically go together. The symptoms of polymyalgia rheumatica are bilateral proximal muscle stiffness. So first of all, the symptoms are bilateral. If a patient says just one joint like the shoulder or the hip is involved, they are probably talking about something else. In addition, the muscle groups that are involved are the proximal muscles. So these are the muscles highlighted in this image on the screen here. This includes the neck and torso, the shoulders and proximal arms, and the hip and proximal thighs. And then finally, the main complaint patients have in this disorder is stiffness. It's not a disorder of muscle damage and muscle weakness. It's that the joints feel stiff and it makes it difficult for the patient to use the joints when they want to. The symptoms are classically worse in the morning. So patients in a board question will classically describe difficulty dressing, for example, difficulty combing their hair. These are things we all do in the morning that require us to use our shoulders and our hips. As I mentioned before, polymyalgia rheumatica does not cause muscle weakness. This is a disorder of inflammation of the joints and the membrane surrounding tendons. So it leads to what patients describe as muscle symptoms, but actually the muscles are not inflamed and are not damaged. And that distinguishes this disorder from myositis, which we're going to talk about later on. So especially in terms of board questions, if they are describing polymyalgia rheumatica, strength testing will be normal, and the creatinine kinase level will also be normal because there is no muscle damage occurring in polymyalgia rheumatica. Patients may complain of muscle pain and myalgias, especially in the shoulder. This is a classic complaint. But remember what I said before, the strength testing will show that the shoulder is normal and the CK level will be normal. And then in addition, because this is an inflammatory disorder, patients can sometimes have generalized symptoms of inflammation like malaise, fever, and fatigue. So the way you diagnose polymyalgia rheumatica is by identifying the characteristic clinical features. Remember, it's largely going to be a complaint of muscle soreness and stiffness, but not weakness. On blood testing, the CRP level and the ESR level will be increased. And then in addition, you should know that this disorder, because it's inflammatory, responds very well to glucocorticoids. In fact, symptoms usually completely resolve. And this is sometimes a trick used clinically. If a patient has diffuse muscle stiffness, you can administer glucocorticoids as a trial. If the symptoms completely go away, then you know you are likely dealing with a case of polymyalgia rheumatica. Next disorder we'll talk about is fibromyalgia. This is a chronic pain disorder where patients develop widespread musculoskeletal pain. It's common in young women, usually 20 to 55 years of age. And about 30 to 50% of patients have a coexistent diagnosis of depression and anxiety. So especially in a board question, this will be a young woman who has known depression or anxiety who then develops musculoskeletal pain. The cause is unknown and it's diagnosed clinically. There's no muscle biopsy findings. If you do a muscle biopsy on patients with fibromyalgia, it will be normal, and all the lab tests will be normal, including the SED rate, the CRP level, and the CK. If the symptoms completely go away, then you know you are likely dealing with a case of polymyalgia rheumatica. Next disorder we'll talk about is fibromyalgia. This is a chronic pain disorder where patients develop widespread musculoskeletal pain. It's common in young women, usually 20 to 55 years of age, and about 30 to 50% of patients have a coexistent diagnosis of depression and anxiety. So especially in a board question, this will be a young woman who has known depression or anxiety who then develops musculoskeletal pain. The cause is unknown and is diagnosed clinically. There's no muscle biopsy findings. If you do a muscle biopsy on patients with fibromyalgia, it will be normal, and all the lab tests will be normal, including the SED rate, the CRP level, and the CK level. Women who have this disorder usually complain of diffuse musculoskeletal pain that comes and goes. On examination, they classically have point tenderness, usually in specific anatomic locations. Shown on the screen here are some of the classic trigger points for fibromyalgia. If you press on these areas during the examination, you can often elicit pain in patients with fibromyalgia. Fibromyalgia is relatively common. You will see many patients with this disorder in clinical practice. Unfortunately, we really have a poor understanding of the disorder and we don't have very good treatment options. Some of the things that have been shown to be effective are exercise, and especially in a board question, one of the first things you want to recommend to a patient with fibromyalgia is to stay active. In addition, there is some evidence that tricyclic antidepressants, especially amitriptyline, may help, and also SSRIs. For the remainder of this module, I'm going to talk about the inflammatory myopathies. These are autoimmune muscle disorders that involve muscle inflammation. And the two major disorders in this class that you should know for the Step 1 board exam are polymyositis and dermatomyositis. They classically involve skeletal muscle and therefore present with weakness, although you should be aware that they can sometimes involve the heart and lead to myocarditis and decreased myocardial function. In both of the myopathies, we'll talk about dermatomyositis and polymyositis. The key test for diagnosis is a muscle biopsy. They both have classic findings on muscle biopsy that I'll show you in a few slides. And then because these are inflammatory conditions, the mainstay of treatment is immunosuppression. So when a patient presents with muscle weakness from muscle inflammation from one of these disorders, usually corticosteroids like prednisone are started, and that makes the symptoms go away. And then long-term, they are treated with a steroid-sparing agent. These are drugs like azathioprine or methotrexate that also suppress inflammation, but spare the patients from the side effects of long-term steroids. There are classic muscle features of both of the inflammatory myopathies we're going to talk about in a minute that you need to be aware of. So you can recognize these in a board question. So first of all, patients with an inflammatory myopathy will complain of muscle pains, which is myalgias. In addition, they will report the slow onset of progressive symmetric muscle weakness. And remember, it's symmetric. So if they just say one arm or one leg is weak, then they're talking about some other disorder. If they say both arms and both legs are weak, then they may be talking about an inflammatory myopathy. The hallmark is that the disorder begins with proximal muscle weakness. So the proximal muscles are the muscles closest to the midline. These are the same muscle groups that are affected in polymyalgia rheumatica. But remember, in polymyalgia rheumatica, there is no muscle weakness and no muscle inflammation. That's how you can distinguish the inflammatory myopathies from PMR. So when patients have weakness of the proximal muscles, they will have difficulty doing things that involve the hips and arms. So it'll be hard to rise from a chair. It'll be hard to lift the legs to climb stairs. Another classic complaint is that patients can't comb their hair. That's because you have to raise your arm over your head to comb your hair. The fine hand movements, however, will be intact. So patients will be able to grip things normally, at least in the initial stages of the disorder. If it goes untreated for a long period of time, then distal muscle weakness can occur, but that happens late in the disease. There are also some common laboratory findings that you can see in both dermatomyositis and polymyositis. First of all, in both disorders, there is an elevated creatine kinase level. That's because there is ongoing inflammation of muscle tissue and muscle cells are spilling CK into the serum. The ESR can be elevated because these are inflammatory disorders, although this is not a reliable marker because sometimes it can be normal. Anti-nuclear antibodies, or ANAs, are also typically abnormal in the inflammatory myopathies. Now, these can be elevated in lupus and other autoimmune disorders. An elevated ANA level is not specific for the myopathies, but it is positive in 80 to 90% of patients. And then there are a couple of very strange antibodies that you should be aware of for the inflammatory myopathies. And the one you always want to remember is anti-Jo1. This is an antibody directed against a cellular enzyme called histodidyl tRNA synthetase, and it's the most commonly abnormal antibody in myositis. And then there are a couple of other strange antibodies like anti-MI2 and anti-SRP that can also be abnormal, but the one you definitely want to remember for your board exams is anti-Jo1. To understand the biopsy findings in polymyositis and dermatomyositis, we need to review a little bit of the terminology of skeletal muscle tissue. So if you look at this picture on the screen here, we've got a bone, and then we've got a tendon, and then we've got a skeletal muscle here. So the skeletal muscle is made up of muscle cells or myocytes. They're also called muscle fibers. This is one right here. And surrounding each individual fiber is a layer of connective tissue called the endomysium. That's connective tissue surrounding each muscle fiber. However, the muscle fibers are bundled together in these fascicles of a whole bunch of them together. And then each fascicle is surrounded by a membrane called the perimysium. And then the fibrocytes, they're also called muscle fibers. This is one right here. And surrounding each individual fiber is a layer of connective tissue called the endomysium. That's connective tissue surrounding each muscle fiber. However, the muscle fibers are bundled together in these fascicles of a whole bunch of them together. And then each fascicle is surrounded by a membrane called the perimysium. And then the muscle itself is made up of multiple fascicles. All surrounded by a layer called the epimysium. But in terms of understanding the inflammatory myopathies, as we'll see, they can have inflammation involving either the perimysium or the endomysium, and that's what distinguishes the disorders. In polymyositis, the classic finding is endomysial inflammation. So remember, the endomysium surrounds an individual muscle fiber or cell. So if you look at this biopsy on the screen here, we've got a muscle cell right here, and there are inflammatory cells surrounding it. That is inflammation of the endomysium, the hallmark of polymyositis. And when you study the inflammatory cells, the predominant cell type in polymyositis is CD8 positive T cells. And so now let's talk about dermatomyositis, which has the same muscle symptoms as polymyositis, slow onset proximal muscle weakness. The distinction between dermatomyositis and polymyositis is that in dermatomyositis, as the name implies, there are skin changes, and it is also diagnosed by characteristic findings on muscle biopsy. So in a muscle biopsy in dermatomyositis, what you see is perimysial inflammation. This is shown on the screen here. So here we've got a whole bunch of muscle fibers, and the inflammatory cells are outside that bundle of muscle fibers involving the perimysium. That is classic for dermatomyositis. And the characteristic cell type here, in contrast to polymyositis, is CD4 positive T cells. There are many, many skin findings that can occur in dermatomyositis, but there are two classic ones that you should know. The first one is called a heliotrope rash. A heliotrope is a purple plant. So a heliotrope rash is a purple discoloration of the skin. It classically occurs on the upper eyelids. On the bottom right side of the screen is a patient with dermatomyositis who has a heliotrope rash on the eyelid. Second classic finding is the presence of Gottron papules. These are symmetric red scaly papules that occur on the hand and finger joints. They're symmetric, so you'll see them on both hands. And this is a picture of a patient who has Gottron papules on the bottom left side of the screen here. Note the red scaly plaques and papules that you see on the back of the hands and the finger joints. It somewhat resembles psoriasis, and these are Gottron papules. And both of these findings are pathognomonic for dermatomyositis. That means if you have a patient with muscle weakness in these findings, you have a diagnosis of dermatomyositis. Some other skin findings in dermatomyositis are shown on this slide. First of all, patients with this disorder can develop a malar rash, just like patients with lupus. And you should be careful in board questions. Many people immediately think of lupus when they see a description of a malar rash, but that can also be seen in dermatomyositis. Two other Signs you can see in this disorder are called Schall and V signs. These both happen for the same reasons. They are red-brown discolorations of the skin that occur in sun-exposed areas. When this occurs in the upper back, it looks like a shawl over the shoulders, and it's called the Schall sign. When it occurs in the neck and upper chest, it's called the V sign. That's because the chin blocks some of the sunlight and usually creates a small area with no rash, so the rash looks like a V, and that's called the V sign. And then finally, some patients with dermatomyositis develop what's known as mechanic's hands. These are cracks and fissures that occur on the palms, just like a mechanic might get. They have increased pigmentation, therefore there's darkening of the skin of the palm, and that's called mechanic's hands. I'll finish this video with this slide and mention that malignancies are associated with both of the inflammatory myopathies. The reason for this association is not clear, and there's stronger evidence for an association between dermatomyositis and malignancy than polymyositis, but nevertheless, both of the inflammatory myopathies are associated with an increased risk of malignancy. And the type of malignancies that occur are usually adenocarcinomas. So patients with these disorders can develop adenocarcinoma of the cervix, lung, ovaries, pancreas, bladder, stomach, and even some other organ systems. And you want to remember this for step one. It commonly comes up on exams. And that concludes our video on muscle disorders. Hello, everyone, and welcome to our module on neuromuscular disorders. In this video, we're going to talk about disorders that involve the neuromuscular junction. The neuromuscular junction is where a motor neuron meets a muscle fiber and can depolarize the muscle fiber and cause muscle contraction. And there are two classic neuromuscular junction disorders. The first one is myasthenia gravis, which is far more common, and the second one, which is much more Eden myasthenic syndrome. And for both of these disorders, what you want to focus on is what's going on at the level of the neuromuscular junction. That is what they're going to test you on the step one exam. So let's start by reviewing how a neuromuscular junction works. Shown on the screen here is my own drawing of a neuromuscular junction. This is a motor neuron here at the top. This is a muscle fiber at the bottom. And this is a synapse here in between the motor neuron and the muscle fiber. So when the motor neuron depolarizes and it reaches the end of the neuron, that will open calcium channels, which will allow calcium to rush into the neuron. Calcium will trigger the release of acetylcholine, which is stored in vesicles inside the motor neuron. That will lead to acetylcholine release into the synapse, where it will bind to nicotinic receptors, and that will lead to muscle depolarization and muscle contraction. There's an enzyme found in the synapse called acetylcholine esterase. It will in time break down acetylcholine, and that will lead to loss of this stimulation of the muscle fiber. And on this slide, I've summarized the important points from that drawing. So presynapse is where you find the nerve terminal, the ending of a motor neuron. Depolarization of the nerve terminal leads to calcium influx, and that leads to release of acetylcholine vesicles. On the other side of the synapse, the postsynapse, you find the motor end plate. This is where acetylcholine binds to nicotinic receptors, and that leads to muscle depolarization and contraction. And then in time, acetylcholine is broken down by the enzyme acetylcholine esterase. So now we're going to talk about specific neuromuscular junction disorders, and these diseases are very easy to understand if you just know how a neuromuscular junction works. We'll start with myasthenia gravis, which is an autoimmune disease where antibodies are produced that block nicotinic acetylcholine receptors. Basically, the antibodies compete with acetylcholine for receptor binding, and this leads to muscle weakness. And so it should be very easy to understand that you can make a diagnosis of myasthenia gravis by testing for acetylcholine receptor antibodies. Let's talk about the clinical features of myasthenia gravis. The hallmark of this disorder is something known as muscle fatigability. If you repeatedly stimulate a nerve, it will release less acetylcholine with each additional depolarization. What this means is, in myasthenia gravis, if you ask the patient to perform a muscle maneuver over and over again, you will see the muscles weaken with use. So to understand this, you need to appreciate that when a motor neuron depolarizes, it releases a large amount of acetylcholine into the synaptic cleft. If you give it time to reaccumulate acetylcholine, it will again release a large amount of the neurotransmitter. However, if you depolarize the nerve again and again in rapid succession, you will see a little bit less acetylcholine with each additional depolarization. That's because the neuron doesn't have enough time to build up the acetylcholine levels. In a patient with myasthenia gravis, this will lead to marked weakening because some of the receptors are blocked by antibodies. So as you diminish the amount of acetylcholine, you diminish the amount of muscle contraction. You should also be aware that this disorder classically presents with eye problems like diplopia, which is blurry vision, and ptosis, which is drooping of the eyelid as shown on the screen here. The eye muscles are very small and they are very vulnerable to blockade of just a small amount of nicotinic receptors. And 50% of patients who present with myasthenia gravis present with complaints of blurry vision or a drooping eyelid. You can also sometimes see speech, chewing, or swallowing problems. These are bulbar symptoms related to the cranial nerves and the brainstem. Those nerves also innervate relatively small muscles in the jaw and neck, and therefore many patients present with these type of complaints. The treatment of myasthenia gravis in clinical practice is complex, but what they want you to know for your boards is that the mainstay of treatment is with acetylcholine esterase inhibitors. These are drugs like neostigmine, pyridostigmine, and edrophonium. All of these drugs decrease acetylcholine metabolism and therefore raise acetylcholine levels in the synapse. If we go back to this drawing, acetylcholine esterase breaks down acetylcholine. So if you inhibit it with a drug, this means that whatever acetylcholine is in the synapse will stick around longer, and this can improve symptoms of myasthenia gravis. The disorder is also treated with immunosuppressants because, as I told you before, it's an autoimmune disorder. But what they want you to know for step one is that the acetylcholine esterase inhibitors will help the symptoms of patients with this disease. Patients who have myasthenia gravis will sometimes present with a complaint of an exacerbation of their condition. Basically, they will say that they are getting weaker, and this can occur for two reasons. The first reason is that they are not taking a high enough dose of their acetylcholine esterase inhibitor. The second potential reason is something called cholinergic crisis. This means they are taking too much acetylcholine esterase inhibitor, too much medication, and there's so much acetylcholine in the synaptic cleft that the muscle has become refractory to acetylcholine. This is a phenomenon called cholinergic crisis. The way you can differentiate between these two causes is by doing something called the Tensilon test. Tensilon is the trade name for edrophonium, an acetylcholinesterase inhibitor, and edrophonium is short-acting, so you can administer it at the bedside, and it will quickly boost the levels of acetylcholine in the synaptic cleft. If muscle function improves, this means that the patient needs a higher dose of their acetylcholinesterase inhibitor that they take chronically. However, if muscle function does not improve, it means that they are in a cholinergic crisis and you need to lower the dose. So this is sometimes done clinically, especially with patients who have a lot of eye problems that you can easily test clinically. You can administer a dose of edrophonium and see if the symptoms improve. If we go back to this drawing, there are two reasons for an exacerbation of myasthenia gravis. One is that there is not enough acetylcholine in the synaptic cleft. So if you give edrophonium and inhibit acetylcholinesterase, the levels will rise and the patient will get better. The other reason is that they are chronically exposed to very high levels of acetylcholine and the nicotinic receptors are no longer responding. In that case, when you inhibit acetylcholinesterase, you will see no change in symptoms. Now, you should be aware that the Tensilon test may lead to complications, and it's high yield for you to understand these for the step 1 exam because all these complications relate to the fact that edrophonium diffusely increases acetylcholine levels, and therefore it generally activates the parasympathetic nervous system. So all these complications are basic elements of the parasympathetic nervous system being turned on by edrophonium. So patients given the Tensilon test and edrophonium may begin to salivate, they may develop abdominal cramping from bowel stimulation, they may develop asthma from bronchoconstriction, and they can also develop bradycardia. You can basically think of myasthenia gravis as a disorder of the thymus, and that's because most patients have some thymic abnormality. About 85% have hyperplasia and about 15% have a thymoma. And this is important clinically because the myasthenia gravis usually resolves with thymectomy. And this is also important for your board exams because a key test in a patient who presents with new onset myasthenia gravis is imaging of the mediastinum, either CAT scan or MRI, because you want to know whether or not there is a thymic abnormality. Moving on, now let's talk about the Lambert-Eaton myasthenic syndrome, or LEMS. This is also a disorder of the neuromuscular junction, just like myasthenia gravis, although it's much more rare. This disorder is a paraneoplastic syndrome that classically occurs in small cell lung cancer. In Lambert-Eaton, there are antibodies produced that are directed against presynaptic calcium channels, and when you block those channels, you prevent acetylcholine release. So in the case of Lambert-Eaton syndrome, the diagnosis is made by detecting VGCC antibodies, which are antibodies against voltage-gated calcium channels. Going back to this slide, in Lambert-Eaton syndrome, you have blockade of voltage-gated calcium channels. This means that when the neuron depolarizes, calcium cannot get inside to trigger the release of acetylcholine. Therefore, less acetylcholine is released and you have muscle weakness, similar to myasthenia gravis. Now, a couple of important distinctions between Lambert-Eaton and myasthenia gravis. Lambert-Eaton affects the presynapse. It affects
Actual goals, bro. For real, actual goals. I'd love it.
the motor neuron weakness, similar to myasthenia gravis. Polarizes, calcium cannot get inside to trigger the release of acetylcholine. Therefore, less acetylcholine is released and you have muscle weakness, similar to myasthenia gravis. Now, a couple of important distinctions between Lambert-Eaton and myasthenia gravis. Lambert-Eaton affects the presynapse. It affects the motor neuron before the synaptic cleft. Myasthenia gravis affects the postsynapse. In that disorder, there are antibodies blocking nicotinic receptors found on the other side of the synapse. This is an important distinction. It's a basic feature of the two disorders they'd like you to know for step 1. The typical presentation of Lambert-Eaton is slow onset symmetric proximal muscle weakness. So this is a distinction from myasthenia gravis, which usually presents with eye symptoms, and Lambert-Eaton, it often presents with proximal muscle weakness. Now, this is the same symptom you can see in myositis. However, in myositis, there's inflammation of the muscles. So you see elevated CK levels, and patients usually have muscle pain or myalgias. In Lambert-Eaton syndrome, it's purely a nerve problem, so you'll see normal CK levels and no muscle pain or myalgia. So what do you need your proximal muscles for? These are your muscles like your shoulders and your hips. So you need those to walk, to rise from a chair. You also need them to comb your hair, where you lift your arm over your head. So these are the types of things people will complain of when they have proximal muscle weakness. Another feature of Lambert-Eaton syndrome, and one that distinguishes it from myasthenia gravis, is the presence of autonomic dysfunction. And this is important for you to understand. So in Lambert-Eaton syndrome, the neuron has a problem getting calcium in. This leads to decreased acetylcholine release onto muscle fibers and muscle weakness, but it also leads to decreased acetylcholine release onto autonomic nervous system structures. You can't get this in myasthenia gravis because the problem is with the receptor on muscle tissue. All you can get is weakness in myasthenia gravis. In Lambert-Eaton syndrome, because nerves can't depolarize and release acetylcholine, you see muscle weakness problems, but you also see autonomic dysfunction. So classically, these patients complain of a dry mouth from less salivation. They can also get erectile dysfunction and constipation, and this is all from decreased acetylcholine release in autonomic nerves. If patients repeatedly use their muscles in Lambert-Eaton syndrome, this will improve their symptoms. This is the opposite of what happens in myasthenia gravis, where there's muscle fatigability. This is because if you keep depolarizing the neuron, you will eventually get more and more acetylcholine into the synaptic cleft, and whatever acetylcholine is there can work normally because there's no problem with blockade of nicotinic receptors, and therefore the symptoms get better. And this is a key distinction between Lambert-Eaton and myasthenia gravis. If you do the Tensilon test in Lambert-Eaton, you will see a mild improvement in muscle function. Basically, administering edrophonium leads to some increase in acetylcholine in the synapse, and this will lead to more contraction. But this is much less effective than in myasthenia gravis. In myasthenia gravis, the Tensilon test can completely reverse the symptoms. All you see in Lambert-Eaton is a mild improvement in muscle contraction. The main way to treat Lambert-Eaton is to treat or locate the underlying malignancy. So sometimes patients who have a lung tumor present with this syndrome. What you need to do is image the chest to identify the lung tumor. There is a drug used to treat this. It's called guanidine. It inhibits potassium channels in neurons. So by blocking potassium channels, you make it easier for the calcium to trigger acetylcholine release, and that leads to more acetylcholine release. I think they're unlikely to ask you this on your step 1. I'm just pointing it out so you know this. The more important thing is to know how to distinguish Lambert-Eaton from myasthenia gravis. And to help you keep the two disorders straight in your mind, I've made this summary table. So the cause of myasthenia gravis is antibodies against nicotinic acetylcholine receptors. The cause of Lambert-Eaton is calcium channel antibodies. Muscle use, repeated muscle use worsens myasthenia. That's fatigability. It improves muscle function in Lambert-Eaton. Eye symptoms like diplopia are classic for myasthenia. They are less common in Lambert-Eaton. Proximal muscle weakness is rare in myasthenia, but it's a common symptom in Lambert-Eaton. In terms of the autonomic nervous system, symptoms are absent in myasthenia gravis. The problem is with nicotinic receptors, so you shouldn't see any issues with the autonomic nervous system. In Lambert-Eaton, however, autonomic symptoms are common. That's because this affects calcium channels on presynaptic neurons. Those calcium channels are found not only in motor neurons, which innervate muscles, but also in neurons in the autonomic nervous system. And then finally, if you perform the Tensilon test, you should see complete symptom reversal in myasthenia gravis, a very dramatic effect. You see only mild improvement in Lambert-Eaton. And that concludes our video on neuromuscular junction.
Oh my God. God save me, man. God save me.